Good morning. This is Dr. Deuk, and it is January 14th, 2020. And we're going to be performing Deuk laser disc repair on our patient who has horrible back pain and right leg pain. So right-sided sciatica and back pain. Looks like a pseudodisc at 5'1", right? Can we see that on the lateral view? Our patient is here for a 3-level Deuk laser disc repair for lower back pain. I know this patient from racing. He knows my son Arius. We were just chatting earlier about the race this weekend in Miami, which went really bad for Arius because Arius' Go-Kart was sliding all over the place. And we were just talking about how that shouldn't be happening. How are you, sir?
Good, thank you.
All right, good. So, I don't know if you ever did any of these with me. Basically propofol sedation, but not yet. Maybe a little fentanyl before then to ease him up. And let's try to get that blood pressure down. Perfect, perfect. All right, we're going to get started, okay? Are you comfortable where you are?
I am.
And we have him strapped in? Okay. So, you're going to be awake for the very beginning. All right?
Wonderful.
And then when I'm ready, I'm going to put you to sleep. The anesthesiologist will. And but I need you awake to help me in the beginning, okay?
Yeah.
So it's not an okay as in you have a choice. All right? That's my hand on your back, by the way.
Okay.
So I'm going to be talking to you at times, and I'm going to be talking to the rest of my staff at times, okay? And I need to see the MRI. That's good, actually, right there. It's perfect. Leave it, just right there. The first thing I'm going to do is I'm going to give you some numbing medicine.
Okay.
And you're going to feel a little pinch and a burn on your back. That's normal. Don't freak out. If you feel pain at any time during the surgery, just say ouch.
Okay.
Don't try to get off the table and help me.
I don't think I'll do that.
All right, it's real important you lay still, okay?
Yep.
All right. I'm going to be feeling around your back for a second, okay? I'm just feeling your bony anatomy. All right. You're going to feel a little stick and burn. That's normal. I'll let you know if we're having any problems, okay?
Yeah.
I don't expect any, but you're a big guy. We want to not put you too much asleep. We want to keep you awake so you can help me out.
I'm sorry.
Huh?
I'm sorry.
No, you're good. Trust me, you're good. All right. I may need a longer. I may. I probably will. Shot? All right, so hold on. Let me just look at this one more time. So this, it's an S1, S2 pseudodisc. There are some, oddly enough, some changes in the pseudodisc. But we're doing the 3 discs above the pseudodisc. The pseudodisc is almost as wide as a normal disc. It's about 75-80%. And on that x-ray, it's hard to say, but we're going to have to figure it out. I'm going to need to see on the lateral view further south. All right. Shot? let's go with a lateral view. May need to start a little higher. So for those of you watching, our patient has scoliosis in the lower back. It's called degenerative scoliosis. So are you going to use a pulse mode this time or not?
It's actually a little bit clearer.
On the pulse mode. Okay. Whatever makes it clearer, let's get it done. I need to see further back. The L5S1 isn't too bad, but I need to see to the right a little more. Can you do that?
Lower the table, quarter-inch height, do you think
Yeah, I think quarter-inch lowering is okay. Shot. All right. So I want to try to get that 5-1 disc as clear as possible. Shot. You feel that? I've got to see. You got to zoom out or something. I got to see where I am at. So our challenge, one of the challenges with this patient is that we have, let me know if this is uncomfortable for you, okay? Shot. This patient is a big guy. I mean, how tall are you? Shot. 6 what? 6'9". So he's a big guy. He's like a mountain. That's a compliment, by the way. Shot? Is that right? No surprise. Yeah, I know who Legree is. He's built a few engines for Arias over the years. Shot? He's never given me a really good power. That's the only complaint I'd have about him. Shot? Yeah, never enough to win. Let's get an AP, see where we are. But you know, he has his favorites. He's Brazilian. He's going to favor the South American drivers over a North American driver. I don't use anybody. The team has chosen Wolcher. You know, that's who they use. And I don't have any say because I'm not footing the bill. Shot? Let's give me a lateral. If I was paying for it, I probably wouldn't be using Wolcher. Just because the last race we just did this weekend, the engine was a piece of junk, in my opinion. It's one of his rental engines. You know, when I went to talk to him, Shot, I said, Arias is going to be racing on your engine again. And he said, oh, I didn't know. So, Shot, clearly the team didn't tell him that Arias was going to be racing with him this weekend. Shot, which, you know, I don't know if it would have made a difference or not. To me, I think it would have. What can we do about the L5S1 disc there? Can you help me with that? Maybe raise the table or lower the fluoro? Can you lower the fluoro? All right, so I don't know, do you think bringing the collimator in or raising the table? Which one? Raise the table a quarter-inch, please. So I'm going to be talking to the team as well as talking to you from time to time. All right, do you think we're looking down the axis of that disc? I think it's close. Monica, what do you think? It looks like we could probably get a little better with some wag. You want to try wagging? before I go any further? Yeah, it's not much, probably 3 degrees at most, 2, 3 degrees. Question is that better? It almost looks better to me. What do you think, Monica? All right, let's keep that position in mind and let's try some other wagging and see if we can make it worse. So part of the issue is you're a big guy, so it's really hard to get a good x-ray shot through you. You got a lot of mass. And that's what we're trying to do right now is figure that out. What do you think, Monica? Huh? That looks pretty good. What do you think? You're good right there? Lock it in? All right. So that's good. Let me just think for a moment. If I want to start more lateral or if I'm happy where I am. I think I'm happy where I am. Shot. I feel the facet. Need to be a little bit north. So at least, you know, he knows now that Arias is on the team. Shot. I don't know if it makes a difference. I don't know that his power can compete with RPG. Is that uncomfortable? Yeah. I don't think he can compete with RPG. I don't think he can compete with Alex. No. Alex, I mean, you saw what happened in seniors. They had literally, in my opinion, 4 out of 5 of the top starters in the final. You know? Norberg wasn't there in the top 5. He started outside the top 5 because I guess something happened to him in one of the heat in the pre-final. But if you were to take Norberg and put him up where he belongs in the top 5, they had 4 out of the top 5. They had 1, 2, 3. We're too far north, I think, but I really don't want to mess up where you are. Did you move something? Because it looks different. You okay? Yeah. Is that uncomfortable? Yeah. So RPG had literally 4 out of the top 5 starters for the final. In my opinion, position 1 through 4. I mean, there's clearly an engine discrepancy there. Shot? I mean, they don't have 4 of the best drivers out there. We were completely underpowered. But we also had our rear sliding everywhere. So how much was the... You and me both, man. I was so disappointed. You have no idea. Huh?
Everyone was fighting to get rid of grip.
We had no grip. No grip in the rear. No grip whatsoever. Yeah, I agree. To me, I would have moved the seat back a little bit. But, you know, then they said, well, we may get some entry push. All right, let me have an AP. I suggested moving the seat back. Yeah. It sounds like the cart's getting squirrely. It's unstable. I would have moved the seat back too. If I could just go back and redo it. Looking good. Looking good. Let's go back to a lateral. You okay? Your nose is itching. Well, I'm glad that's the worst of your problems right now. We're getting close to being where we need to be, which is good. We're almost there, and this is the hardest one to do. So once we get this guy, you know, locked and loaded, then we can do the others much easier. Shot, I know you are. But I can't do that yet. Do you have the longer one? We're probably going to need it. I don't know for sure. Shot. But it's looking like it. Shot. Wow. Shot. You have a guide wire ready? Shot. You're definitely not making it easy for me. Take. Guide wire. Any pain? No? You're a tough guy. Shot. Beautiful. Long needle. Sorry. It's the truth, though. Okay. See how I did that?
Yes, sir.
That's very important. It's done in that correct sequence. You understand, Shot? Are you comfortable?
Yeah.
About as comfortable as you can be, right? For having back surgery?
Yeah, I don't feel too bad.
I haven't told our audience who you are, obviously, but you know, somebody close to you obviously went through the same treatment not so long ago. We won't mention names. Shot. So I want to advance the needle. Shot. Without moving the guide wire. Shot. 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 You doing okay? Shot. So I think we can still see we're there. The bevel. Shot. All right. Shot. 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 So we had to use a little different technique because our patient is a big guy and a lot of soft tissue. So I used the switch out method. We may be okay without this. Yeah. So, how clear are we at the next level? Monica, are you pretty happy with that? It looks pretty dang good to me. Right? So, this is the hardest part of the surgery, by the way. And you're doing fantastic. It's the hardest for me and probably the hardest for the patient as well. And I appreciate your patience. Shot.
I'm ready to go to sleep and wake up and be over though.
Oh, you will go to sleep and wake up and it'll be over. That's that I believe is going to happen for sure. Shot. But this part I need you awake. Sorry. Shot. But when you wake up, I would expect all that pain to be gone. You feel that? Interesting. Okay. Let me try to make you more comfortable. Hold on a second. I'm going to give you some more medicine, okay? Should make it better for you. Shot. So have you ever tuned a KR chassis before?
Yeah.
Really? Shot. Who was the driver? Lockhart?
Yeah.
Was he any good? Shot.
He wasn't bad. His dad just sort of chased his
Shot.
tail all over the place.
What was it?
His father sort of chases his tail all over the
Oh.
place.
Yeah, that's what fathers do, Shot. We're always writing our kids to do better.
Trying to run him 2 classes, and that's never really that good.
Shot. Oh, I've done that with Arias. I had Arias run junior and junior shifter once. Let's go with the bigger.
Well, that's a little different because at least it's a shifter.
Yeah. Oh, I like giving Arias the challenge of running 2 classes. You know, not too direct drives.
Pretty far apart, it's one thing, but when the breaking points are so close
Shot.
together, it's kind of.
Were you talking about the sessions?
Well, no, he's running the K100 and then the X30.
Oh, I see.
So the breaking points aren't exactly the same, but they're not that far off.
Shot. Well,
It's confusing for the child.
why would the breaking points be different, Shot?
Just because of different speeds.
But I mean, are the tires different? Shot.
I'm not sure.
Yeah, I mean, if the tires are different, I could understand the braking points being different, but the chassis setup should be the same, right, for the 2?
He's on 2 different chassis.
Oh, he was on 2 different chassis.
Yeah.
I don't understand. You mean like a KR and something else?
Yeah. Yeah, Tony Stark.
Oh my God.
KR.
Shot. Why would you do that? That's crazy.
Well, that's what I mean. You're just kind of sabotaging the child. And then he wants to practice on a different chassis, an Intrepid.
Shot.
I mean, that's just insanity.
That I don't understand that.
Well, I don't either. You got to practice on what you're racing.
That is true. Even I know that. Shot.
What the hell are you going to practice on, you know?
Where do you feel that, Shot?
I don't know.
Well, is it in your back or down your leg? Good.
Ow.
Just relax. Just relax. You're fine. Everything's okay. Almost done with this part. Shot. Yeah, this is one of your 2 bad discs. So, I apologize. I can't give you any more numbing medicine right now. Shot. Yeah. You're doing great, by the way. I apologize. It's a much better picture at 5-1 now. Look at that shot. Okay. It's a much better picture at 5-1. Interesting. One more? Okay. Yeah, we couldn't even see that before. Why is it better now? Maybe, huh? You okay, buddy? Have we given him any fentanyl? Yeah, so you're doing the right thing. We're almost done with you being awake. I'm 2/3 of the way done, and the heart is 2/3, by the way. So hopefully this one won't be quite as bad, okay? So just bear with me. We're almost there. I think we're going to be able to get everything done through 1 7mm incision. There's no one else in the world that can do this for you. You know that. Interesting. Oh, there it is. Okay. So, for those of you watching, I haven't really talked much about the surgery yet, and you haven't asked any questions. Shot? I'll take care of that, okay? Just give me a second. So, do you know what that is? That's the fascia. I'm on the fascia, so that's innervated and uncomfortable. Probably because he's inflamed there from like muscle spasms. But you can see we're nowhere near the facet or the disc with this third one. But most people don't have sensitivity of the fascia. Like they don't even feel it, but he does. He's very sensitive to it. So I'm Dr. Ara Deuk Majan, CEO and founder of Deuk Spine Institute. And shot. Our patient is undergoing a procedure called the Deuk laser disc repair. It's the most advanced spine surgery in the world for degenerated and herniated discs that cause pain. It's only done at Deuk Spine Institute in 2020 and prior to 2020 as well. Because I haven't taught anyone else how to do the procedure yet. Not that I don't want to teach them, it's just that they haven't come. So we're getting the word out about the surgery and why it's so much better than traditional back surgery. Though our patient probably wouldn't agree right now that it is better. Just relax, okay? Relax. I've got you. We're going to give you some more numbing medicine. Shot. All right. So my goal right now is to make it to this last. Where are you feeling pain? In your arm or your back? Okay. The surgery is an alternative to a fusion surgery. So if this patient wasn't having this procedure done, he would require a fusion to fix his pain. A fusion from me. And not just a fusion, but a decompression infusion and osteotomy. So I gave him some numbing medicine. The anesthesiologist is helping him as well. You okay, buddy? You all right? And we've known each other for years. Interesting. That's part of my problem, is that this special needle shot has a stylus that is moving a little bit. It's not as secure as traditional shot. The other needles I use are disposable shot, but they're not long enough to do the job, so I have to use something else shot, and that's what I'm using right now. So that something else is a longer needle shot, because this patient has a very, very thick back shot. That's better. Shot. Shot. So we're getting in the foramen now. I need an AP, lateral and an AP. Let's see where we are. Lateral and an AP. Okay. So we're a little bit lower than I want to be probably. But that's okay, I can fix that pretty easily. I'm just trying to get into the right area of the spine. Alright, so we're pretty far off, and let me, where's the lateral again? There. So I need to be a little bit more medial. Alright, that's good to know. Shot. Shot. Lateral. So I'm aiming for the last disc, which is the 3-4. We've already gotten into the 4-5 and 5-1, and now I'm aiming for 3-4. Shot. And we've given our patient some more sleepy or numbing medicine. Shot. To take away the pain. And he's a bit more comfortable right now. Shot. Alright, let's get an AP. Well, let me just get a little further in and let's see where we are. Huh? Good. AP. So we're just starting to get to the foramen at 3-4. You're doing fine. Everything's good. Just relax. Alright, that's good. That's really good. We're perfect. Right where I want to be. Back to a lateral. So you can see the spine is twisted because the patient has scoliosis. And we encounter this in about 50% of our patients. They have scoliosis, they may have listhesis, but we don't do a fusion surgery because they don't need it. Every other spine surgeon out there wants to do a fusion. The fusion, if I did the fusion surgery, it would work for this patient. But it would be a massive surgery with an incision this big, literally. We'd have to rip out all the bone and ligaments in the back of the spine. We'd have to put in cages and do an inner body fusion and a posterior fusion and screws and rods. And we could do it today and we could do it outpatient. But this patient doesn't want a fusion. And I don't blame him. I wouldn't want a fusion either. Just, you're doing great. Hang in there. We're almost done. Shot. Just got to finish this and we'll be done. And then we're almost ready to put him to sleep. Shot. That's really nice. There it is. So we're ready to wake him up. Let me know when he's ready. I need him being able to feel discomfort. Did he get just sedative or did he get analgesic? Okay, good. Are you? So we're going to do our discogram right now, the evocative discogram. Obviously, he's going to feel something, but don't worry. And as soon as I'm done doing all three, which will take about 3 minutes, 4 minutes, then we can put him to sleep. So, are you awake? Yeah. All right. The hardest part is done. I've gotten into the discs that I think are painful. I just need to verify that. Are you comfortable? Huh. How bad is that on a scale of 1 to 10? Give me a number. Give me a number. How high did it go? All right, scale of 1 to 10, 10 being the worst pain. Okay, all right. Was that where you typically get your back pain? Yeah. So that was concordant. I don't think we have a reliable number. Yeah, I can give you a number. I need you to give me a number on the next one, okay? Just do your best. Pick a number between 1 and 10. 10 being the worst pain, 0 being no pain. No. You'll know. Yeah, how bad is that? 8. All right. Yeah. All right. And one more to go and we'll be done, okay? And we're going to put you to sleep. Is that where you typically get your pain, though?
Yeah.
Yes, so it's concordant. So what we're doing, folks, for those of you who don't know, we're actually testing these 3 discs because there's no test in the world that will tell you for sure if this is the patient's typical daily pain they get every day, except for a discogram. Exactly what I'm doing. And that's why we do it, number one, to figure out are we in the right place for the patient's pain, but also number 2, I need the blue dye. How bad is that on a scale of 1 to 10? How bad?
I don't know.
Is it as bad as your pain ever gets?
I don't know.
What's the highest number it is?
Right now,
Yeah, what's the highest it went?
I don't know.
I don't even
All
know
right.
if it was pretty high.
Is that where your typical pain is?
Yeah.
Pick a number.
8.
8. All right. So L5S1 is 8. Hold on. We're ready to put him to sleep. You want to count from 1 to 100 for me out loud, Scott?
I'm not that smart.
Count from 1 to 100 by ones.
2, 3, 4.
Yeah, you're doing great. Keep counting. When you wake up, your surgery will be over.
9, 10,
Shot.
11, 12, 13, 14,
You're doing great. Keep counting.
16, 17, 18, 19,
Shot.
20, 21, 22,
Yeah, keep counting.
23, 24, 25, 26,
Shot.
28, 29, 30, 31, 32, 33, 34,
Shot. So at this point, I've got the guide wire in.
36, 37, 38, 39, 40, 41, 42,
Oh, yeah, I forgot. This is the hard part.
45, 46, 47, 48, 49, 48,
Keep counting.
I do. Oh, that would be fine.
Yeah, yeah.
42, 41, 40,
Keep counting.
39, 38, 37, 36, 35,
Watch it.
33, 32, 31, 30,
Keep going. You're doing great.
29, 28, 27, 26, 25, 24, 23, 22, 21. Is my butt still showing?
You're doing good.
20, 19, 18, 17, 16, 15, 14, 13,
Nice and loud so we can hear you.
12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Keep and count again.
2, 3, 4, 5, 6, 7,
What's this?
10, 11, 12, 13,
Can you hold some pressure here, please? Shot.
Sleepy?
Shot. So this is really the hardest part right now, actually, because it's an unusual circumstance. Shot. Where I have to put a larger needle. Let me have it. So by putting pressure, I can hold the guide wire pinned while I get the needle out. Shot. We're at 5-1. I don't want to lose that guide wire. Let me have another guide wire. Or give me the stylus. Stylus should be fine. Never mind. Hold on.
Thank you, Krista. Thank you.
Shot. Yeah. That's the problem. It wants to take the guide wire out with the needle. Shot. Hold this for a second. Shot. You can see that guide wire, right?
Yes, sir.
Shot. 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 Tell me if you see the guide wire moving. You still see it there? Shot. How's he doing?
Go ahead and I got a blood pressure down, but other than that,
Let me see the another guide wire.
got why
So, because of his girth, we're having to use a longer access needle, which is creating a problem on the guide wire side because the guide wire is only so long, and it's trapped with the needle. So as we remove the needle, the guide wire wants to come out with it, which we don't want to happen. So I've got to figure out a way to keep the guide wire in there. There it is. Shot. There it is. Shot. Yep. Very nice. Seems to be working so far. Shot. That was hard. But that's called improvisation. And sometimes in surgery you have to improvise. There's no other way but to improvise. No matter how many times you've done the surgery, you're going to encounter a challenge that you've not had before or that's rare. Now, Shot, I can tell you right now that we're going to have to bury the endoscope to the hilt. He's asleep.
So you can find a 26-year-old single level
Right.
pounder for me? My first one?
Dude, trust me. I wish I could make it easy for all of us, right? But this is the reality. This is America. We have a lot of big people, big boned people, big bodied people. I wish everyone was as svelte and perfect as I am. Which I'm not, by the way. I got on the scale the other day and nearly broke it myself. My wife is giving me a hard time. She's trying to feed me salads. She knows how much I hate eating salads. It's hard when you get to over 40 to maintain an ideal body weight. Shot. I mean, it takes a lot of effort. And I'm not for going to the gym at night. I got too much other stuff to do. I actually have a coral farm where I grow coral. Shot. And I have to manage the farm at night. I have an employee who does it in the daytime, but at night it's me.
Is it in the water offshore or is it farm?
Oh no, it's an aquaculture farm. Shot. It's
For softies or hard
I grow hard coral, soft coral, both, mostly acroporas, but also, what am I doing with this?
That's it?
No, I need a tube.
Alright. I have an unfortunate agricultural brown soft mushrooms in my tank that I want to get rid of.
You have what kind of mushrooms?
Oh, they're just
Ugly brown mushrooms?
ugly brown.
Are they mushrooms or are they polyps? So
No, they're
anthers,
mushroom. They're mushroom corals. They get this big and
are they hairy? Are they rhodactis or are they discosomas?
I don't know.
Are they smooth surfaced?
Yeah.
All right, let's see what we got here, shot. So because we're taking the instruments basically to their limit, you know, we're going to be really at shot. Hello. We're going to be really kind of taking them to the limit. Shot. You'll see what I mean. Huh? Shot? I don't want to damage the end of that because I have to interface that with the fluid adapter. Shot? Huh. Huh. God, unreal. Scott, if only you knew the trouble I was going through for you. Shot? All right. Normally this procedure is much quicker, much easier, but again, because our patient is a big man, I think he's got Viking blood for like at least 3 men. He's a huge guy, I mean big guy, and so that means my part of the surgery is going to be extremely difficult. Okay, good. So far, shot. Just want to make sure I'm not advancing the dilator, which is, thank God it's not advancing. Sometimes you'll get a little piece of tissue at the end, and that'll cause the dilator to advance. You don't want it to advance. You want the tubular retractor to slide over the dilator. And I can still see the marking, so I know where the fluid adapter has to be positioned. Shot. So we're inside the disc now. I've gone almost as far as I need to. Shot. So I have a coral research lab and I have a farm, both. And I've been doing research on corals for, well, I mean, real research for about almost 2 years now. I've discovered what's killing the corals in the world. But nobody really believes me because I'm a neurosurgeon. And I'm not a marine biologist, but I went to UCSD, Scripps Institute of Oceanography, and I studied marine biology there, which is one of the top marine biology programs in the world. Yeah, La Jolla. I went to UCSD for undergrad. My major is biochemistry, cell biology, and I have a second in chemistry. So, of course, I've worked in labs, I've done lots of research, but it's funny because, you know, nowadays everything is internet, and, you know, you're being judged by the masses who honestly aren't qualified to determine whether or not a real scientist's work is valid or not. And then, of course, you have the peer review process, which is totally corrupt, right? It doesn't work because peer reviewers have their own biases and agendas. You saw the editor-in-chief of the New England Journal of Medicine resigned, right? The chief editor, because of the corruption in peer review process. So, long story short, what's killing the corals is a parasite. An enteric parasite that eats the corals from the inside out. But it's not as simple as that, because you can help the coral kill the parasite by doing certain things with the chemistries of the water, which I've discovered more recently. But ultimately, the infection will take the coral's life, and that's what's killing all the corals.
So it's not just the water quality.
It's not.
The water quality plus the parasite.
Correct. You have to have the parasite to kill the coral. You can have deterioration of water quality, including temperature, other labs, but with the coral uninfected, it won't die. And everyone's seen this, but they don't understand how to interpret it. I do now. I've tried explaining it to people, but they don't want to listen. So it's funny because it's probably the most significant ecological discovery in the last 50 years. And yet I haven't pushed the discovery at the scientific levels. But it's probably, it's probably a Nobel Prize for whoever discovers what's killing all the corals. And it's not global warming. That's what people are trying to blame it on. Some marine biologists believe it's bacteria, some believe it's virus, but I know the truth, it's a protozoan. All right, so this is probably the more stimulating part of the surgery. Let me get the laser off while I wipe. Did you see the tissue on there? So basically we're inside the L5S1 disc, right through the annular tear, right through the herniation. And what allowed the herniation, which is a little bubblegum piece of the nucleus pulposus, this is the center part of the disc, what allowed this to happen was the tear in the outer containment system called the annulus fibrosus. Now the annulus fibrosus has two parts. It has an inner half and an outer half. And the inner half has no blood supply and no nerve fibers. So you can't feel a tear on the inside of the annulus. And there's no inflammation associated with an inner annular tear. However, the outer annulus does have an innervation by what are called somatic afferent fibers. So somatic afferent fibers project to the brain, to a certain region of the brain called the somatosensory cortex, which is the part of the brain that lets human beings feel exactly on their body where something is coming from, a sensation, whether it's tickling, itching, or pain. So the somatosensory cortex is the part of the brain that's located behind the central sulcus. How do I know this? Because I'm a brain surgeon. Okay? And I've studied it extensively and trained in it and operated on the brain many times. So point is that I'm an expert in brain anatomy, brain physiology, and anything else brainy. And so I'm telling you that there's sensory inputs that go to the brain from your body that are somatotopically organized, and there are sensory inputs that are not somatotopically organized. So there's two types of fibers that go to the brain, two pathways. There's sensory somatic afferents, and there are sensory visceral afferents. Visceral afferent fibers go to parts of the brain that don't have a somatotopic organization. In other words, there's no roadmap in that part of the brain. So patients don't really feel localized pain when they have a visceral, like your intestine or something, for example. An example is if you have appendicitis and the appendix is not ruptured, you have vague abdominal discomfort everywhere. That's visceral afferent information getting to the brain. You can't localize it to your appendix, to the right lower quadrant. However, when the appendix ruptures, then the serosa around the appendix does have somatotopic organization. So then once the inflammation spreads outside the appendix into the peritoneal cavity, then those fibers in the peritoneal cavity do project to the somatotopic regions of the brain, and you can actually localize the pain to the right lower quadrant where the appendix is. That's just an example. We're talking about discogenic pain right now. And the pain that comes from a tear in the annulus and a herniation that's in the back side of the disc, either right or left or center, is innervated by nerve fibers that are actually going to the specific areas of the brain that project for specific parts of the body. So whether it's your right toe, your left toe, it has a spot on that part of the brain, and if it's activated, your brain knows it's coming from your right toe or left toe. Okay? So we call that somatotopic organization. You can look it up and understand it on Google. Long story short, the reason why annular tears in the back of the disc with herniations and inflammation there cause specific localized pain is because that part of the disc, the back and the back sides, not the sides, but the back sides, right where the herniations are, right where the nerve root runs, that's somatotopically organized in the brain and the sensory cortex. So patients know exactly where the pain's coming from, their lower back. They can point to it with their finger. On the other hand, the front of the disc and the sides of the disc our visceral afferent fiber innervation. So it's more diffuse, less localized, less specific, and it's not going to the somatotopic cortex. It goes to other parts of the brain that are more ambiguous and nebulous in terms of localization where the pain's coming from. So this is something nobody understands or nobody knows about. It's something that I put together and discovered and reasoned. Can somebody check my phone? From where? Melbourne? You can answer it. So right here, this is the tear. This is where his back pain has been coming from for years. And he's dealt with back pain for years. Who is it? What do they need? Sure. What's the patient got? What does the patient have? Are they neurologically intact? They can put her in a rigid collar and send her to me in clinic tomorrow. Unless she has other injuries that she needs to be admitted for. Thank you. So that's an example of, I'm on call for the hospital. So the emergency room has a patient with a fractured spine. They're calling me to come see the patient. And I'm managing with the emergency room doctor's help problem over the phone, because they don't need a neurosurgeon to show up and put a collar on a patient. They can do it themselves. And then I can see the patient tomorrow. If the patient was not neurologically intact and they were weak from the fracture because their spinal cord's being compressed or a nerve root's being compressed, then I would have to do surgery on that patient right away. All right, so the patient here that we're operating on currently, this blue stuff is the dye I put in earlier. Remember, during the discogram. I put in two types of dye. One is a dye that allows me to see on the x-ray machine. All right, we call it radio opaque. And that dye is called omnipaque, right? The second dye I put is a vital dye that's seen with light, not x-ray. And that's the blue vital dye. And I joke about it, but the blue is the Deuk Spine Royal Blue. That's why we use it. So I'm the only surgeon in the world to do this procedure with the blue dye, except for Dr. Anthony Young, who taught me. And the dye itself, he explained to me, stains degenerated disc. So where do you get degenerated disc? You get degenerated disc from inflammation acting on the nucleus pulposus. The dye does not stain the annular fibers. See the white fibers here? These are annular fibers. The dye won't stain the annular fibers because they're a different kind of material. The nucleus pulposus is made up of proteoglycans. And proteoglycans are basically complex carbohydrates. And proteoglycans bind to the vital dye and they stain blue. So the nucleus pulposus, the stuff that's supposed to be in the middle of the disc, stains blue if it's degenerated. If it's not degenerated, it's white. The reason why the vital dye stains to degenerated nucleus pulposus is because the dye binds acidic molecules, and degenerated disc is acidic, non-degenerated disc is not acidic. So the blue is staining the herniated degenerated disc that's degenerated because of the action of inflammation on the nucleus pulposus over time causes the disc to become, the nuclear material to become degenerated. You can see that the nucleus pulposus located deep within the disc, the normal stuff is not degenerated. It's because there's no inflammatory tissue affecting it, because it's located deep inside the disc, in the center of the disc where there is no blood supply. So you can't have inflammation. So you can't have degeneration. When you see a degenerated disc, it's due to the inflammatory tissues, what's called neovascularization and neoneurulation, growing into the center of the disc from the outside. So you get a vascularization of the annulus from the outside to the inside from chronic inflammation. It's the chronic inflammation that drives the neovascularization. So it's a really interesting process that nobody else understands, but we discovered it here at Deuk Spine. And basically, have elucidated the very complex pathophysiology of discogenic pain as a result of our studies over the years, my work over the years, Dr. Deuk work. So much of this has been published, some of it is not. I don't believe anymore in the publication process in this country. I've lost faith in the peer review and publication process because it's so corrupted. And you really have to be, you know, buddies with people that are on the editorial board. It's become a I scratch your back if you scratch my back situation over the last 30 years. And believe me, I know firsthand directly that scientists will call up somebody else and say, hey, I've got a paper I want to get published. Will you help me get it accepted in the journal? I'll put your name on the next paper I write, or I'll put your name on this paper, or I'll put somebody's name that you want me to put on this paper. And so you get all these publications with, you know, 10, 15, sometimes 20 doctors on there. And you know damn well it didn't take 20 doctors to do all that research, but they're actually scrubbing each other's backs in a very corrupt, organized way, which disgusts me to no end. It's not true science. So the problem is twofold. Number one, the paper is not scientific enough with its merit to be published, but they have to use politics and corruption to get it published. And number two, tit for tat dealings below the public eye. Is he okay? Huh? Do you want me to stop? Yeah, you can lighten him up, because what I'm doing right now is going to be a little bit stimulating, but I don't mind him being more awake. Does that make sense? So don't have to make him so deep. He won't come off the table. That's the biggest concern from our standpoint with him being light. I don't mind if he feels a little discomfort as long as he's safe and we don't lose his airway. So you can lighten him up. And this right here, what I'm doing, should start waking him up a little bit, because this is the painful part of the disc. All right, stand by. I need a grabber. You need Mike's help? All right.
We have a couple questions.
All right, let's do some questions then. By the way, this is the scarred in disc herniation right here. It's literally scarred in. Okay, this is where all the pain's coming from. That 12 o'clock position. And it has clearly been scarred for a long time. You can see the pinkish tissue there too. We are going to get to that. I just need to adjust the angle so I can attack it better. There's your tear right there. Okay, that's the annular tear. Go ahead with a question.
In regards to your racing conversation from earlier, one of our viewers is wondering, Dr. Deuk, what kind of racing fuel do you use in the Go-Kart?
So somebody's asking with respect to the racing that my son Arias does. For those of you who don't know, Arias is a national champion. He won, he beat everybody, basically be number one in the United States. He also beat the South American champion and the Canadian champion. So the racing fuel they use is standard for everybody. You're not allowed to use anything but what they give you. And that racing fuel is usually an octane 97 octane. This is for go-karts, not for cars. If it's a car racing fuel, it may be a higher octane. But for go-karts, its standard is VP 97. I think Scott is trying to add something to the conversation. Is he talking or snoring? Okay. Sounded like he was trying to chime in on the racing fuel. Yeah.
And we have another question.
Yeah, a little more volume on the mic, please, because I can't really hear your voice, Sean. Go ahead. What's the next question?
The next question is, one of our viewers is wondering, is this the tallest/stockiest person you have done DLDR on? And will you ever consider longer guide wires for the future to make the similar surgery easier?
Yeah. All right, so is this the tallest, stockiest patient I've ever done DLDR on? I would say yes. It's probably one of the top two. I've done somebody else just like him in the past, but it was probably a good 8 years ago, maybe 9 years ago. So I've not had to break out those special needles in many years. I mean, at least 8 years. I mean, Luis knows he's never seen them come out. But thank God Luis is organized, and he had them available and had them ready to be used. So I'm grateful for that. Yeah, so I would give this patient either number 1 or 2 on stockiness and girth. Should I consider longer guide wires in the future? Absolutely. If I had if I had a lot of patients like this, I would definitely invest in longer guide wires. As a matter of fact, I'm going to ask Luis. I was going to ask him after this case to look into longer guide wires. So it's a very good thought, and I do appreciate you mentioning it. And certainly, I don't know if they make longer guide wires. We may have to have them custom made, but I think probably another 10 centimeters would be good. For sure. And you can see the guide wire length is not the issue. It's actually getting the needle out without taking the guide wire out. That's really the problem. And that's where I struggled with. So we may struggle again on the next disc. You can see the annular tear right there. It's all gelled up from scar tissue. And we're going to just debride it, clean it up. And you can see the end plate of S1 on the left side at about 10 o'clock, 11 o'clock now. That's the end plate, the vertebral body end plate. This is the last of the tear right up here. How are we doing? So yeah, you can keep him even lighter than he is. A lot lighter. He's not moving at all, so I'm fine with that. I can tolerate a little bit of movement. And yeah, so I know you probably want to keep him lighter. Definitely, I'm in agreement with you. Manage his airway a little bit better, if you think. Huh? Yeah. All right. So you can see some of the inflammatory tissue right here. So the thing about chronic inflammation in the body is that when there's a chronic inflammation, it actually calls for ingrowth of blood vessels to support the metabolic activity of the chronic inflammation. In other words, inflammation is energetically expensive to the human body or any animal. To run an inflammatory process in the body, you have to expend energy. So think about that. Your food gets consumed and digested and dissolved and absorbed and then distributed. All that energy is distributed throughout the body. And when somebody has a focus of chronic inflammation somewhere in their body, whatever that may be, that chronic inflammation area is going to call for energy all the time. All the time. So the body responds to it by doing lots of very interesting things. Most notably, there's a redistribution of blood supply to that area, where the blood supply to that area gets enhanced dramatically. Okay? Think about it like farming, okay, and agriculture. What do farmers have to have? Water. They must have water. So if there's a large farm area and there's not enough water going to it, then they're going to take the nearest river and they're going to create a tributary. I don't know what it's called, but you would basically divert the river water over to the farm. So you're creating these channels of water, and you would create many, many, many channels depending on how big the farmland is, how much water you need, how much the crop and everything. So think about inflammation the same way. This disc right here, it had very little blood supply until the herniation occurred, and then when the herniation occurred within the annular tear, it stimulated an inflammatory response. The body recognizes that herniation as a foreign attacker, invader, and then the body attacks the herniation, and it attacks it with an inflammatory response. It does not attack it with an immunological response. It attacks it with an inflammatory response. So your immune system doesn't go after it, your inflammatory system does. And that's because the nucleus pulposus is what's called pro-inflammatory. It elicits an inflammatory response. So it's the inflammation that's causing all the back pain. So by getting rid of the source of inflammation, which is the interposed nucleus pulposus within the annular fibers, you are getting rid of the back pain. Why am I sharing all my secrets to the world? Why? Because, you know, someday I'm going to die, and I want this knowledge to be passed on. I want other people to benefit, because right now I have the knowledge and other people don't. Nobody else knows this stuff. And so if I die, it dies with me. And this is one of the secrets of the known universe, but it needs to be shared so that other people can benefit from this type of procedure directed at the annular tear and debridement of the annular tear. The only thing I ask is that I get credit for creating this surgery, which of course it's been peer reviewed and published, so I should have that already in the National Library of Medicine. Obviously it's been documented. All right, we're just about done with L5S1. That there is the end of the annulus fibrosis. You can see at 12 o'clock epidural fat and epidural veins. This is the end of the tear. The laser is very effective at stopping bleeding as long as I have access to the bleeding vessel. This is all fat up here at 12 o'clock. It's billowing out into my surgical field, which I don't want. So I zap it down a little bit, do a little bit of, what do they call it, lipo irrigation. Well, I'm not really sucking. I guess I am. Lipo lasering. So, why is there fat near this annular tear? I'm going to ask Luis. Give him a chance to shine. Oh no, no, Luis, don't tell me. Huh? Inflammation, good. Because inflammation needs energy, and fat has lots of energy. And fat is the most dense storage form of energy in the human body. Every other energy form we store requires water. Fat does not. If human beings had to store all their energy they have in fat in water-soluble compounds like glucose or any other energy source, ATP, NADPH, FADH2, or even glycogen. If we had to store our energy in the form of glycogen or sugar, we would weigh like 600 pounds. So fat is not water soluble, it's hydrophobic, and it can be packed together tightly, densely, so there's lots and lots of energy stored as fat. So that's why there's some fat around this inflamed disc, is to feed the inflammatory energy needs.
Are we going to call these
Lipoablation, we should charge extra for it, right?
Yes.
All right, we're done at L5S1, laser off. I'm going to show you the L5 nerve root. It's right up in there, in that little fatty bundle. Why do nerves have fat? Oh, let me have the laser back. I want to get this one little more piece. Why do nerves have fat around them? Because nerves are very metabolically active. Hey, lay still, Scott. You're doing good. I need more laser. There we go. Yep. You're doing good. Just lay still.
His nose is itching. He's just turning his head.
Yeah, okay, good. I don't mind that. All right, all done. Done. Off.
Lights on, please.
So that's it for that level, folks. By the way, I know I make these surgeries look easy, but don't try them at home. Actually, to be able to do surgery like this, a surgeon is, oh, that's a nice, very good suction. A surgeon needs to be very well trained in normal surgery and normal anatomy before they can do something like this. And you have to be able to manage the complications that you may create with this surgery. To date, the Deuk laser disc repair that you've just watched has had 0 complications. 0 complications in 13 years of surgery and over 1,000 procedures, not one complication. That's pretty incredible. Lay still. There's no other surgery in the world. Keep that needle away from us, or guide wire, or whatever that is, until we're ready. So, pretty remarkable to have a spine surgery. Lay still. Everything's okay. You're doing great. I don't know if he's awake or not, but I'm just telling him. I know, I'm telling the audience. You know, it's always, if you're somebody coming out of deep sleep and you're a little confused, you want some guidance. You want some reassurance. Everything's going good. So we're done with L5S1. Next is going to be L4-5. I'm putting a little bit of pressure on the paraspinous musculature because I don't want any hematoma in the muscle. Hematomas in the paraspinous muscles. So there's part of the problem, is this thing is kind of kinked. I say we get a new guide wire that's straight. Okay? Not that I'm prejudiced or anything. Who laughed? Huh? Hopefully I got somebody to laugh. Do you have a new one? She's getting a straight one? Let me just wait. Because it's so critical, and let's just see if the straight one can help us. All right, Sean, you have another, those are fine normally, but I want to just optimize this. I want to stack the deck in my favor. Any questions, Sean?
We do have a few viewers who are listening to ask the patient to stay still, and they're wondering if the patient is awake and if they can hear you.
No, the patient's not awake. The patient is not awake, but what happens is if you're sleeping in bed and you're completely asleep and someone pinches your finger or your toe, you're going to withdraw your finger or toe. You're going to pull your leg back basically away from that painful stimulus. Okay? That's called a reflex. This is good.
That's good?
Yeah, that's called a reflexive movement. And it happens at a subconscious level. It happens at the level of the spinal cord itself. So our patient is asleep, totally unaware of what's going on, but their body is reacting to discomfort, just like you would if you were asleep as well. All right, we need to get the floor back in here. So it's called a reflex movement. A reflex movement. All right, reflex movement. So reflex means you don't think about it, it just happens on its own. What can we do to improve that picture? Why am I having trouble positioning this, placing this? There we go. Shot. All right, so let's see what we can do to clean that up. That's not acceptable. You had a much better job before. I don't know if you need to bring the collimator down, if you need to do something, but I need a better view of the back, the facets to the disc. Shot. All right, if we can do better than that, I kind of need it, but if not, I understand. Shot. You can kind of see the guide wire sitting in the needle, by the way, right at the back of the disc. Now it's in the disc. Shot. How's he doing? So, yeah, the patient is asleep. However, they're just, yeah, this is going to be a pain in the butt again. They're just reflexively moving. You know, reflexive movement is, gosh, it's as ancient as humans are. It's the first movement that we learned, that we developed a long time ago. You know, it's one of the most basic types of movement. I hate to use the example, but if you take an earthworm that has no brain and you push on it, it moves. It moves away from the pressure, moves away from the stimulation. Shot. Humans have that same basic reflexive behavior. They move away from noxious, we call it noxious, Noxious, which is basically bad stimuli. Is that him moving?
Yeah.
Shot.
He goes, when he's awake, he wants to scratch his nose, and then during waking,
Shot.
then when he's asleep, he wants to scratch.
No problem. Shot. That's fine. As long as you just let me know how we're doing, I'm fine with it. Shot. Lay still. Shot. Shot. Jordan, you got to do better than that, man. There we go. See, I don't know what you just did, but it's better. You got to figure it out. Okay? I need you to figure it out. So if you need Monica back in here, get her back in here. Any more questions, Sean? That's a good question.
We do have one. A viewer asks, bone welding to promote healing was once considered experimental, but is
Shut.
now used a lot on bike and motorsports athletes. It's becoming more mainstream now. Is it likely that DLDR will end up going the same route?
And I missed the first part. Something is becoming more mainstream?
Bone welding or PMFT?
It's called bone welding?
Yes.
Honestly, don't know what that is. I've never heard that term before. I'm sorry. Is there another name for it? Is that the same as fusion? Are you talking about for spines or some other type of bodily injury? I apologize. I honestly don't know what bone welding is. It may be a terminology used for something else, like fusion, in which case I understand that. But otherwise, I don't know what bone welding is. Please forgive my ignorance on it. Wow. Good stuff, huh? Shot. Let's make sure our guide wire is still where it needs to be. It is perfect. As my grandmother used to say, thank Scott. The other day my wife told me she was watching me operate, so if she's watching today, she'll get a kick out of that one. My grandmother is Armenian, and God bless her, she was one of those tough old, Middle Eastern women, but grew up in LA, Los Angeles, not Louisiana. And there's a large Armenian population. Lay still. Everything's okay. So just for those of you wondering, when I talk to my patient like lay still, it doesn't mean they actually hear me. But on the off chance they do, I want them to know everything's okay. So some surgeons just will ignore it. They won't say anything. And that's fine. But if I was a patient and I happen to be, if I was awake by the off chance, then I would want to know everything's okay. So, just so you all know, we have no way of knowing if the patient is completely awake. But what the anesthesiologist does is they titrate the patient, they look at certain things like the eyes, the mouth, the breathing, the body movements, the heart rates, the blood pressure. They look at like a bunch of things to figure out, is this patient right now awake or not? Perfect. Shot. So the anesthesiologist has to assess many different variables and parameters to determine what level of anesthesia their patient's at and whether they're safe. Because sure, we can knock everybody out, right? I could knock this guy out myself. I don't need an anesthesiologist for that. The problem is knocking someone out and keeping them alive. That's where the challenge is. Look at Michael Jackson. He knocked himself out and died. That can happen to every single patient that undergoes propofol sedation. The only reason why they don't die is because they keep breathing and they protect their airway. And that's why we hire the anesthesiologist, mainly to monitor the airway and the sedation, but also to maintain the blood pressure and other vital functions like that by giving medication. So don't be alarmed or disturbed because we're talking to the patient. I don't think he's awake, but on the off chance that he is, I just want him to know everything's okay. Shot. So I know it can be confusing to somebody who doesn't spend a lot of time in the operating room to understand these things, but all of it really comes down to what we call compassionate care for our patients. Shot. All right, so here we are with the dilator at L45, and we're entering the foramen, and that I can feel the disc shot, or the facet in this case, and I'll push past it. Now this has a big herniation. I actually can feel the herniation right now. It's huge. This one is, I think, worse than the last one. And we're right on the herniation. Shot. So now I'm gonna, you can see we're not even at the back of the disc. Normally, we're kind of a centimeter behind it because this is a big herniation. It's at least a centimeter behind the disc. It's in the foramen on the nerve root. So I'm gonna push the herniation back into the disc through the annular tear. Shot. Everything's okay. Sometimes I just talk to myself too. Who got a chuckle out of that one? Good, good. That's what I thought. You get my sense of humor. Is that the latest right there? Is that it? All right. So let me see if I can advance this now without the guide wire. Shot. I think I can. I think we're good. Take that for a second. I'm going to bring the guide wire out. It's a lot easier to hammer this when there's no guide wire. Shot. So I feel pretty good about that. It feels like it's going through the annular tear. So yeah, that's another thing that is interesting worth talking about. You're watching me do surgery. You're seeing me through the video camera. You're seeing with your eyes. You're using your visual senses to understand what I'm doing. But there's also a feeling part. And there's also a hearing part. And there's also a smelling part. Usually we like to minimize the smelling parts. But the hearing part, I'm listening to the patient snore. I'm listening to the anesthesiologist. I'm listening to the machines to make sure that everything is good and stable. You guys can hear a lot of that, but not all of it, like I can, because we don't have, Dolby sound. And then the feeling part, you can't feel what I'm feeling. Like I'm feeling resistance right now, right? That's what a surgeon feels. I can feel, as I'm tapping this in, I can feel pushback from the body's tissues. And I can feel like what it should feel like to move through these body tissues. Because I've done over 1,000 of these surgeries, and each one I've done an average of 2.5 discs. So I've really done 2,500. Shot. 2,500 discectomy, Deuk laser disc repairs, whatever you want to call them. They should be called Deuk laser disc repairs because that's what they are. They're a unique procedure with the annular debridement. But I've done 2,500 of these over the last 13 years. So I've learned how to feel like what it should feel like. Shot. So there's also a feel component. There's a sound component, like the sound of this right here, this tapping. It should have a certain sound to it. And I know what that sound is like when it's done properly. Shot. Perfect, perfect. So there's a feel, there's a sound, there's a smell, and there's a sight. What am I missing? Huh? Taste, feel, smell, sound. Isn't there another sense? Nobody's going to help me? All right. Well, we use all of the senses. That's it right there? So I've got to take this dilator out without removing the tubular retractor, which I'm doing successfully. And now we're getting ready to start our second disc. And I expect the third one to be a little bit easier than the second one. So I always like to start with the hardest. I don't know why, but I just do. All right, more questions from the audience.
Skull ball, please.
We have a few.
Okay,
One
let's
of our
have
viewers.
those questions.
One of our viewers on Periscope is wondering, Dr. Deuk, you seem very comfortable doing this surgery. What about some of your first operations with DLDR? Were you nervous?
All right. Yeah, great question. So the viewer says, Dr. Deuk, what about the first few surgeries you did? You're comfortable now. You've done 1,000. When did you get comfortable? What was it like in the very beginning? That's a great question. I don't think I've ever really talked about it. I think I mentioned it one surgery, but it's scary. I'll be honest with you. If you care about your patient and you want them to do well and you don't want a complication, like me, like I have a beautiful complication record. I don't have very many complications at all. The only complications I've ever had in surgery have been the anesthesiologist by overloading the patient with fluids, which is not really my fault, but giving too much fluids during surgery, they can get pneumonia or edema. Or I've had a broken screw, for example. I've had a couple of those years ago, but I changed the company that made the screws and I haven't had a problem. In the neck, I used to have screws that backed out. Hold on, laser. So I was using this one plate that was supposed to be really good for fusions on the neck, and a couple of the patients had the screw back out. And I put the screws in perfect, but it was basically an engineering defect. So when I say complications, I've never had a nerve damage. I've never killed a patient, never had anybody die. But people get pneumonia, they get DVTs, sometimes they get a heart attack. You know, you can't really predict for everybody, but a lot of it is a shared responsibility between the surgeon and the anesthesiologist. So I didn't want complications with this surgery when I started. I was concerned. I was going into uncharted territories. It's kind of like taking a ship, right? In the old days, a merchant ship, and you're going into a sea or an area of the ocean where you've never been, but you know how to navigate a ship. You know how to captain a ship. You know all the basics, and you're really good at it. You're good at navigating. You're good at, dealing with a storm or whatever it is, sea serpents. But the point is that you're pretty much prepared, but you're still going into an uncharted territory. So yeah, that's how I felt. I knew the anatomy. I knew that the passageway from the skin to the disc, I understood it. I knew there was, how to navigate properly. And I knew how to avoid complications. I knew how not to put the tube in too far, not to, break something while I'm in there. I kind of knew what needed to be done, but I hadn't done it before by myself. So I actually I went to training. I went to a cadaver lab. I went and learned watching live surgeries from other surgeons that have done endoscopic surgery. However, doing your first by yourself on your own still is a very frightening experience. It was for me. And it was only frightening because I just didn't want to have a bad outcome. I didn't want to hurt my patient. I didn't want to have a complication. And then it was also frightening for me because I didn't know how well it would work. So here I am doing a surgery. Sure, the patient wants it, but I have a responsibility to my patient to only offer surgeries that actually will work. And so in the beginning, I wasn't 100% sure that it was going to work. I didn't have any experience really on my own. So that was one of my biggest concerns was, is this even going to help the patient? And I worried about that every single patient that I did surgery on. Is this going to help? And so what happened was I still remember the very first patient. I still see her face in my mind as though it happened yesterday. And I saw her back in clinic a week later after surgery. She came in and she was smiling. And I said, gosh, you look very different than when I saw you before surgery where you were in pain all the time. How are you doing? And I expected her to say, well, I took my pain medication this morning, so I'm doing good. And then I was going to try to find out if the surgery even helped her at all. And she surprised me with her answer. She said, I'm doing great. I have no pain. And I'm like, really? Did you take pain medication? And she said, no, I didn't take any pain medication. And so I'm like, really? Your pain's gone? And she said, yes. So I was shocked that the surgery actually worked so well. I was shocked that it worked. I was shocked that it worked so well. And so that was the first patient. Then I thought, maybe I got lucky. The next one probably won't be as good. I don't know. Let's find out. So I did the second one, and that patient came back, and he had complete pain relief again. So it was 2 in a row. And it was after that I really started thinking, my God, maybe this does work, Sure, people do it. The Koreans do it. And a couple of German surgeons at the time did it. But maybe it doesn't really work. And then when I started seeing consistent results in my patients where their pain was literally gone with this procedure, I started to develop a respect and trust in the procedure itself for achieving the goals the patient has, which is elimination of pain in the back or neck and down the arm or leg. So then the issue was, what about safety? Am I going to have a complication? And, the only way you know if you're going to have a complication for a procedure is through time, through experience. And I have always been, since the very beginning, very, very cautious. I know it looks like I don't know what I'm doing here. I mean, maybe it looks like I'm talking to you and I'm not really paying attention. But every little thing that I do in between my conversations with you or whoever I'm talking to or listening to music, every little single second of what I do has been planned out, thought out, tested, and is the very best of what you can do, okay? And so after doing so many of these surgeries, I've basically mastered the technique to the point that I know exactly what needs to be done. And there are basically what are called waypoints. And for anybody that sails a boat or flies a plane, you understand what a waypoint is, or even drives, along a highway. Simplistically, the reality is though this is not like driving along a highway, because driving along a highway you can only go one way or the other. That's it. Up or down, left or right, north or south, east or west. You have a choice, and it's kind of easy, to be honest with you. You just got to stay in your lane. But the highway is already there for you. But somebody out in the ocean, somebody up in space in an airplane, there's no waypoints, there's no markers, there's no road that you follow. You literally have to use little markers on the surface of the earth, and you have to keep looking at them to make sure, laser off, that you're in the right place and you're going the right way. And if you go a little to the left, it's bad. And if you go a little to the right, it's bad. If you go a little too high, it's bad. You go a little too low, it's bad. Same thing in the ocean. When you're in a boat, if you go a little to the left, you could hit a reef and then, sink your boat. This stuff happens even today. You read about it in the news. So navigation, we call it navigation, that part of the surgery where I'm navigating from the skin down into the disc. It's hard, but I make it look easy because I've done it so much and I know exactly what to do. Does that make sense? So in the very beginning, I didn't have that confidence in my navigation. I didn't know everything. And so, of course, I was very worried and scared. Every single case, I would, be very, very worried about every single patient. Now, I've done it so much, I'm like that, commercial airline pilot that runs from San Francisco to LA every single day. You know your markers, you know your navigation, you know your scenarios, short of somebody shooting a laser in your eye or, a bird flying into your engine. You're not going to have a bad day. You know exactly what's going to happen. It's safe, reliable, dependable, predictable. Those are all the kind of qualities that surgeons like about surgery. If you ask surgeons, what do you like about surgery? They like reproducibility, dependable, reliable. They want the same result with the same procedure. It's kind of like when you go out to eat dinner, right? You go to your favorite restaurant because you want your favorite dish, and it has a certain taste, a certain texture, a certain element of satisfaction when you eat that dish. You want that satisfaction of having that. Like I had Chipotle burrito last night, and I had it exactly the way I want it, and it was very satisfying. So, yes, in the beginning I was very concerned. I should say scared to death, but I won't say that because I wasn't scared to death. I'm still alive. But especially with cervical, going through the neck, you know, that was like, my God. You know, that was really freaky. Yep, there it is on record. The truth. I believe in telling the truth to people, and that is the truth. I would be lying to you if I told you I wasn't scared. I was so scared. Honestly, don't know that I've ever been more scared in my life than when I did my first, 5 or 10 cervicals. All right, what's the next question? By the way, we're working on L4-5, and this is the annular tear, and we're getting close to the back of the disc, and you can see that's the vertebral body right there. That's the end plate of L4 on the right, because we're on the right side of the spine. And there's the end plate of L5 there, the superior end plate of 5. Is he misbehaving? Yeah, perfect. Well, does he have a double strap, top and bottom? Luis? Yeah, I would strongly recommend you do a double strap on a big patient like this. Put one on top, one on the bottom. Okay? We have the straps. You should use them. That will keep the thorax in position. Just about done with this disc. Is our next patient here? Yep. So our next patient's going to be a 2-level lumbar laser, Deuk laser disc repair. And we're just about done with this disc. We have one more to go in this patient. I'm really excited because I get to see this patient at the racetrack. And I'm really excited for them to have a new life and have a new lease on their back. This is the annular tear that we're debriding up here, and almost done. They have some listhesis here, Luis? Do they have some listhesis here? Luis is here. Do they have a retrolisthesis at 4-5? Can you tell on the MRI? You have a question there, Sean?
Yes, we do.
Sure.
One of
We
our
do.
viewers is wondering,
Yeah, you can see it.
it
Yes.
seems like you do more lumbar DLDRs than you do cervical. Is there a reason why?
Yeah, great question. Looks like I do more lumbar than cervical. Great question. The answer is that's true. I do more lumbar than cervical. And it's not because I want less cervical or I want more lumbar. It's just whatever patients come into the clinic and see me. So I personally think that people who have cervical fusions, ACDF, should avoid it and have this procedure done on their neck instead. But I think that it's two issues. One, I believe that lumbar problems are more common than cervical. So we call that a prevalence issue, incidence and prevalence. I just think symptomatic lumbar disc herniations are more common than symptomatic cervical disc herniations. So I think that's one, is the incidence or prevalence of the disease is more common in lumbar. And then the second is, not marketing, but education of the public. I don't think the public knows that there's an endoscopic option without fusion for their neck. So we're working on that, but the truth is that we don't have a huge marketing budget. We don't do really any marketing except for some minor pay-per-click on Google. We don't do TV commercials. We don't do movie advertising, billboards. We don't do any of that. All we do is word of mouth, really, and then obviously broadcasting over the internet like we are now to educate the public, you know. And we do testimonials. Our patients who have had the procedure, they'll do a video. Many of them, we don't bother most of them, but sometimes we'll just put one out just to educate the public. But basically, it's word of mouth, you know. My feeling is that if the procedure is good enough, which I believe it is for sure, that the word of mouth will get out and it'll spread that way. We don't do any targeted marketing. We just do a little bit of pay-per-click with Google, and that's it. So it's probably our fault for not more aggressively marketing it, but we just don't have the money to do it. We don't have the budget to do it. So it is what it is. I figure people that want it will spread the word amongst themselves. And I guess just the lower back people spread the word more than the neck people do. So I don't really have another explanation for it other than that. We don't turn anybody away that needs a surgery. As long as they can get it done, we do it. So honestly, I think we really do see probably 3/4 of the patients are lower back pain, and 1/4 of our patients are neck pain and neck problems. So, but we love doing both. We like taking care of both patients. All right, just about done with this disc. Another minute. I'm going to pull back a little further so I can get better access to the back of the tear. Why am I having trouble with this wire, Luis?
Better now?
Yeah, a little bit better. I'm trying to get to 12 o'clock, and I'm not able to for some reason. Little piece of disc herniation there. I can't roll it for some reason. I'm just not able to roll it. There we go. That's better. "30 seconds and I'll be done with this disc." Any more questions?
None currently.
Great. Well, good questions today. Our audience always does a great job of asking really good questions. It's nice to see the questions that come in are very thoughtful, insightful, relevant. Clearly, people wanting to understand what we're doing, why we're doing it, how it works. That's good. This surgery you're watching is a replacement for spinal fusion. Okay? It's a replacement for spinal fusion. It's a replacement for laminectomy. It's a replacement for microdiscectomy. Those are the 3 most common spine procedures done for herniated disc, degenerated disc, and this surgery could replace all 3 of them. So if you've been recommended for a laminectomy, a microdiscectomy, or even a fusion of your spine, I strongly recommend you do this as an alternative. There's no fusion, there's no metal, there's really no downtime. This patient, for example, will be back to work tomorrow if he wanted to. They can drive tomorrow, they can do whatever they want tomorrow, except they can't lift anything over 25 pounds. They can't bend over and pick things up from the ground. So if you have a job that allows you to go back to quote unquote light duty, then this surgery is perfect. You don't have to miss any time from work. We also take workman's comp. If you've been injured at work, your back, your neck, we take those patients at Deuk Spine Institute. So even if you're out of state, we'll take you and work with your attorney or your insurance company, whichever one is reasonable. All right. I just want to get a little more. I'm just not quite satisfied yet. How's he doing? Just need a little bit more right in here and we'll be done.
Probably
I know, I know. Well, we'll get the next one done pretty quick. I'm literally just about done. At least I'm giving him some stimulation for you. Right?
I'll turn the propofol back down again because he's
Yeah.
still obstructed.
Yeah. Does he have any apnea?
I'm sure he does.
Right.
I mean, he's either awake or not.
How come I feel something tickling my feet?
Oh, that's picking hair off that wet spot.
Oh, okay. I thought maybe we had a cat in the OR. Standby laser. How are you? All right, we're done here. Suck all the water out. Standby scope.
Scope off. Okay, good.
This is it for this level. We got one more to go and we're done. All right, last one. Put a little pressure here. I got it. All right, let's get the fluoro back in. Let's get the guide wire back in. Take. Any questions at the moment?
We have a viewer weighing in on the last one about the question with the disparity between cervical and lumbar.
Uh-huh.
They say maybe another explanation for fewer cervical cases
Go
is
north.
that patients are aware of the complications of ACDF and are not aware that DLDR is different.
It could be. It could be that an awareness of complications, but just for the record, DLDR, we've had 0 complications. I think you need to wag. You look like you're off a little bit. Let's wag the fluoro. So for those of you watching, we're taking an x-ray picture from the side. We use the front picture and the side picture, we call it AP and lateral, 2 views, to really do most of the navigation. So, all right, I think I can see the guide wire there. You know, I don't know what the reason is. Honestly, I don't know if the incidence of symptomatic cervical disc herniations is that much less. Shot? I think that it's possible. Shot? I think it's possible that there's just less symptomatic cervical disc disease than there is lumbar. Let me have the guide wire. I think I'm far enough out I can do this. I'm not 100% sure. Yeah, it's a great question. I wish I could get more of the word out. Whew. He sounds like a symphony orchestra. Shot? That's it right there? Yeah, it's kind of dicey here. Dicey in the sense I don't want to... Is he moving again? Somebody help him. I don't want to pull the guide wire out with a needle. Shot?
That's just his head up maybe a little so he's not taking
That's fine. Yeah, I think I got it. Take. I wish everybody knew about the procedure, to be honest with you. I hate to see people undergo... It's not just that they undergo a fusion unnecessarily. It's that there's so many complications from these other doctors doing fusions that it's not just about, oh, I had a fusion, now I can't move my spine anymore. It's really about, I had a complication and I didn't get better, or I got somewhat better, but I still have a lot of problems. It's the bad results of the alternative that bothers me the most. Shot? It's not just the fact that they get a fusion. I've done fusions my whole career as a neurosurgeon. And when I do them a special way that patients do exceptionally well, and my complication rate's really low. But I see most surgeons that do fusions, and their work is horrible. It's shoddy at best. And the patients pay the price. The patients pay the price. That's the problem. And so it's not fair to a patient to pay a huge price for a fusion, like dying for it, which we've seen happen to some patients in this area where we practice with some of the other spine surgeons. Literally, patients die from their surgery, from a fusion. And nobody should be dying from a fusion, okay? Nobody should be paralyzed from a fusion. There shouldn't be nerve damage from a spinal surgery. If the surgeon does the procedure properly, none of those complications will happen. I have to put the dilator in. Are you sleeping? How do you stand and sleep at the same time, Luis? Shot. I'm just giving you a hard time. You know that. I'm really good at giving people a hard time, by the way. Shot. I don't try to be something I'm not on television, but I'm just kind of not a nice person, I guess. When people don't do their job right, I get nasty. Shot. But the good news is I don't discriminate. I give everyone a hard time, no matter who they are. Shot. Even myself. That's the right way to do it. Shot. Okay. So I like where we are. We're right at the tear. You can see the tear right in front of the dilator tip. I'm going to bring the guide wire out, and I'm going to advance this the rest of the way through the tear. Good. Shot. Nice. Let's go a little bit further. Now we're ready to put our tubular retractor. So for those of you who have not seen this surgery before, can you see this, Sean?
Yes, we can.
So if this patient had had open back surgery, their incision would literally be bigger than this. It would probably be, because we're operating on a disc right here, actually right here. We're operating on a disc right here, and we're operating on a disc right here. So to get to those three discs, we would need an incision that went from here to here. That whole thing would be open, moved over, muscles moved over, all the bones and ligaments taken out, cages put in, fusion done, screws and rods, all that. Okay? Will it work? Absolutely. If I did this man's fusion, we would get rid of all of his back pain and his leg symptoms completely. But can I do that, getting rid of his back pain and his leg symptoms, without fusion? The answer is yes. With the Deuk laser disc repair, what you're watching right now. It's the only surgery that will do that, achieve those goals of getting rid of the back pain and the leg symptoms without fusion. It's the only surgery available to do that. Now the problem is, as I said earlier, what bothers me the most is that I see these catastrophes of surgeries that most spine surgeons do. They're horrible. They're absolutely horrible. And like I said, the biggest problem is the patient pays the price for their failures, their inadequacies, their incorrect technique, their incorrect surgical plan, their incorrect approach, their incorrect management of complications from the surgery. Ultimately, patients pay, and you can pay with your life. Shot? And I don't want people to have to pay with their life. I don't want people to have complications. I think spine surgery works if it's done properly. The problem is most spine surgeons don't know how to do spine surgery properly. That's the true problem. They don't know how to do the spine surgery properly. As a perfect example, you're watching the most advanced best spine surgery for hernia disc in the world. How many spine surgeons know how to do it? Almost none. Just a few in the world, a handful. So that's a perfect illustration of what I'm talking about. Surgeons don't know the right way to operate. And that's why the results are so bad with spine surgery. And that's why it gets a bad reputation. But you won't hear that from my patients, because my patients do very well.
Skull bump, please.
That's because we do the right surgery on the right patient. That's very hard to determine what's the right surgery, and then how to do the right surgery. Also very hard. You know, I can look at a brain tumor and I can say, you know what? That brain tumor needs to come out. Okay, good. So you figured out the right thing to do for the patient, take the brain tumor out. Well, guess what? Taking a brain tumor out isn't easy to do. You got to do it right. If you take too much, you take the normal brain around the brain tumor out. If you take too little, you leave the brain tumor there. It'll grow back and it'll kill the patient. All right, if you go a little bit to this way, you're going to hit an artery that's going to bleed and kill the patient during surgery. You go that way, you're going to clot off a vein that's going to thrombose and kill the patient. So the point I'm trying to make is, just like with brain surgery, spine surgery is complex. It's difficult. It has to be done right. And the problem is there's so many, I hate to say it, but buffoon spine surgeons out there. There are 6,000 spine surgeons in the United States, 6,000. Roughly half are neurosurgeons, the other half orthopedic. 95% of them don't know how to do surgery properly. How do I know this? Trust me, I know it. I know them. I've seen them operate. I've seen the results of their surgeries. As a matter of fact, our program in residency in neurosurgery was one of the best in the country at UF in Gainesville. And even my own co-residents, half of them couldn't do spine surgery properly. Because honestly, in my opinion, a big part of the problem is that spine surgery is done by neurosurgeons and orthopedic surgeons. Neurosurgeons, even though 70% of private practice neurosurgery is spine surgery, in academic neurosurgery where we train, it's a much smaller percentage because we're all busy doing brain tumors and pediatric shunts and all this other stuff that has nothing to do with spine. So we honestly don't get very good training. And orthopedic surgeons get no spine training either during their residency at all. So they're even worse off. So you're talking about neurosurgeons and orthopedic surgeons that come out of training and don't know how to operate properly on the spine because they're not getting the right attendings or not the right teachers teaching them the right technique, or they're not getting enough cases because they're busy doing cranial cases all the time. So what I'm saying to you folks is that the reason why spine care is so crappy with respect to surgical care is because there's no standardized treatment, there's no standardized training. And there needs to be standardized training by leaders in spine surgery, like me, in endoscopic surgery. Not the pieces of garbage like Dr. Patrick Jacob that work at Shands Hospital because he can't get a job anywhere else because everyone hates him. And the only place he could work is an academic center, teaching residents how to do spine surgery. Okay? That's, our system is broken, but that's the God's honest truth. It needs to be fixed. The training needs to be fixed. And by the way, the biggest influencer of training of spine surgery, guess who it is? It's the companies that sell the screws and rods. Okay? And so they're teaching all the residents how to put in screws and rods. Well, of course, once you learn how to put in screws and rods, you're not gonna do endoscopic surgery because you get paid less than putting in screws and rods. So if I were to do a fusion on this patient, I get paid about 3 times as much as doing endoscopic surgery. So if you're motivated by money, which most of these guys are, unfortunately, because they got to pay their bills, then you're going to want to do more complex surgery than endoscopic surgery. Why am I looking over my shoulder? Right? It's a nice big TV. So anyway, sometimes the truth hurts, but I'm probably going to get ostracized by my society for telling the truth to the public. But you know what? I don't have an obligation to my society. I have an obligation to patients. That's what the Hippocratic Oath is. That's why you go to medical school. You go to medical school because you want to help people. But you realize that there are other stakeholders that are opposed to helping people. What's best for the patient is not best for the insurance company. What's best for the patient may not be best for the implant company that sells implants and makes billions of dollars in money every year selling implants. You understand? So if you are a doctor who's committed to doing what's best for the patient, you're going to be at odds many times with many other what are called stakeholders. You know, the hospital, for example. Let me tell you how Medicare has put spine surgeons at odds with the hospital. Do you know that Medicare pays the hospital $42,000 for a spinal fusion? It doesn't matter if the surgeon does 1 disc, 2 discs, 3 discs, or 4 discs. You get $42,000 at the hospital for Medicare. Why is that a problem? It's a huge problem, because if the surgeon does 1 fusion, 1 level fusion, L5S1, it costs the hospital about $20,000. If the surgeon does 2 level fusion, it costs the hospital about $45,000, which is what Medicare pays for. If the surgeon has to do 3 levels, it costs the hospital $60,000. So basically, and if you do 4 levels or more, obviously the number goes up. So the hospitals are really don't want surgeons that do more than 1 level of fusion. But that's not what's in the best interest of the patient, you see? And there's all kinds of funny business going on in hospitals where they're punishing surgeons that do multi-level fusion when it's medically necessary and helpful, but it's against what the hospital wants because they're losing money. So it's very complex situation, but I know all the truth of the entire situation for the hospital, for the insurance company, for the patient, for the doctor, for the therapist. I know everything that's happening because I pay attention to what's happening around me, because I need to. I need to understand how to solve problems. To solve problems, you have to be aware of your circumstances, where you're in, your situation. So I've learned to be very aware of what's happening in healthcare in the United States, and unfortunately, I can tell you, the deck is stacked against the patient to get better. And that needs to change, because medicine was created to help the patient get better. Unfortunately, all these other people that have a financial interest in it are basically parlaying for their interests so they can make more money, and in the end the patient loses out or suffers as a result. And that needs to end. And the only way it's going to end is if I make you, the public, aware of it, because nobody else is talking about this but me, because it's dirty. You don't want to talk about it. You can get ostracized, you can get penalized. They'll send the IRS after you. They'll send the medical society after you. They'll send the neurosurgery society after you. They'll send out the battleships and attack you. But guess what? I have a very powerful, well-built castle, because I always follow the law and the rules. So they have nothing on me. They've tried attacking me for years to stop me. What is it? A glove for you?
Yes.
Why? You puncture?
Yes.
So you need another laser fiber.
He said this week.
Did the laser fiber go through, yes or no?
No.
What is about that finger?
I opened my glove, but I don't touch fire with this finger. That's it.
You're positive.
It's possible.
And the fiber didn't go into the glove. How did you puncture your glove?
I was with the syringe with the.
But not with a laser fiber.
Laser fiber.
All right. Yeah, go change your glove. Let go. I've got it. Go change your glove. I've got it.
Yep.
So I guess what I'm trying to say to you is that you're not going to hear this from very many people, because their defenses are weaker, and they're either afraid of losing, but I'm not afraid anymore. I've had a great career, and I think people need to know the truth. And I've always been a patient advocate on the side of the patient. And if somebody else is opposed to the patient, if the insurance company is wanting something that's not good for the patient, I'm opposed to the insurance company. If the government is opposed to helping the patient, I'm opposed to the government. I've already sued TRICARE, for example. I've sued the United States government over payment for endoscopic laser surgery you're watching right now, Deuk laser disc repair. And we won, because the government didn't want to pay the bill after I did 20 surgeries that they approved. They owed Deuk Spine $1 million. So they then said, we don't want to pay, even after the surgeries were done and the patients did great. So we said, that's not right. You said, go ahead. You gave us prior authorization. We have it in writing. And now you don't want to pay the bill after these patients had surgery. We spent all that money. And they said no, because somebody high up at TRICARE Humana decided that, oh my God, we're going to get in trouble for spending all this money fixing people's backs and necks with endoscopic spine surgery. So they ended up doing a sham peer review. Oh, we had the surgeries reviewed by this medical company of doctors. Really? What do they say? They said you shouldn't be doing endoscopic spine surgery. Really? And who was this doctor? Well, guess what? The doctor who was in charge of making the decision was a pediatric oncologist. A pediatric oncologist is a doctor who gives cancer treatment to kids, babies, for tumors. And yet he was now giving opinions about spine surgery and neurosurgery? Makes no sense. But there's a lot of these companies that have popped up over the last 15 years. They're called consulting companies. Insurance companies hire them to give them the opinion they want, which is, oh yeah, that treatment was not necessary, so we don't have to pay for it. Okay? So we challenged this company, and then they said, okay, we're going to send it to our orthopedic surgeons and neurosurgeon group. So they picked another company, another sham company that's designed to be a consulting company to take lots of money to basically give the insurance company the opinion they want. So this group of 8 spine surgeons reviewed all of the cases and came up with the opinion that the surgeries weren't necessary. The Deuk laser disc repair shouldn't have been done. And again, I knew they were lying because obviously they should have been done. The patients needed it. They got better. That was the only thing that was going to really work besides fusion. They didn't want fusion. But these surgeons that lied, they all lied the same way. They all had the same paragraph, basically. They said the same thing. So clearly they were not independent. They were guided. They were shown and told what to say and do. So we challenged them, and we went to court. And we were heard by a federal magistrate from the military, a judge from the military. These are the toughest judges that there are in the entire country. And they always usually rule in favor of the military and the insurance company for the military. But the evidence was so overwhelming that these patients needed these surgeries that even the judge had to rule in favor of Deuk laser disc repair on all the surgeries. So we got a letter from the Secretary of Defense for Health and Human Services apologizing for the sham peer review that they did at TRICARE, Humana, to try to not pay for these surgeries after they were approved and obviously medically necessary, saying that it was indeed a sham peer review process, recognizing the truth for what it is. We took care of our servicemen and women with those surgeries. We gave them their lives back, got rid of their pain in their back, their neck, and they went on to live normal lives. And yet the insurance company tried to screw us out of getting paid. So we stood up to them, we sued them, and we won. We had our day in court, 3 days as a matter of fact, and we won. What does that tell you, America? It tells you if you believe in something, you have to fight for it. So I'm not going to fight all your battles for you. I'm not. You know, I don't think that's right. You all have to start fighting. You have to fight for yourselves and for each other. I'm just making you aware of the problem. We'll fight beside you. We'll fight alongside you. But I'm not going to fight for you. I don't believe that's right.
We have a question.
Sure.
One of our viewers, in regards to the previous conversation, says, in your opinion, Dr. Deuk, which country's healthcare system should we be aspiring to be like? Which one of them provides the best outcomes and overall care for their patients?
That's a great question. So someone's asking, in my opinion, which country has the best healthcare system? Who takes care of their population the best, the fairest? The answer is, truly, I cannot answer this question. I'm not an expert. I don't have enough information, enough knowledge to have even an opinion. I would defer to myself, but I need more information. I would need to study the healthcare systems of different countries. What I've learned, truly learned, is that if a country has given the power of deciding what healthcare should be given to what people, if they've given that power to an insurance company or a company disguised as, you know, as it's an insurance company, but it's disguised as something else, if the insurance company is basically being incentivized to run the healthcare by doing denials, and their payment to them for administering the healthcare of a country is based on denials of care, that country is not going to have good care. The truth of the matter is that the decision to treat a patient with whatever treatment is acceptable should be the decision of the patient and the doctor that they're treating with. That is called the doctor-patient relationship. It's sacred. It's always been sacred for hundreds of years. But now the decision is no longer the treating doctor and the patient's decision. It's the insurance companies. And that's where we've gone wrong. Insurance companies should never be allowed to decide if a patient gets treatment or not, or a specific treatment. Because every time they agree to treat, they're agreeing to cut their profits down. And they're all for profit, essentially. If they're not for profit, then they actually have people for profit working for them making the decisions. So their salaries and paychecks depend on the company making a profit, even though it's not necessarily a for-profit company. Don't let the non-for-profit fool you. So I think the decision about what medical care is given to a patient, whether it's a new blood pressure drug, whether it's a new anesthetic agent, whether it's a new type of brace or a new type of surgery or a new type of diagnostic test, that should be the doctor's and the patient's decision, not the insurance company. So if you want to know where the best health care in the world will be, it's going to be where the patients and doctors have control over health care, not the insurance company. Anywhere there's an insurance company that profits from denial of treatment or denial of testing, that's going to be a country that's suffering. America is the biggest example. Our country was number one in healthcare years ago when I was younger. And now it's fallen to God knows where, somewhere down in the probably hundreds by now, because we have so many people who need medical care who aren't getting it. They're being lied to by their insurance company and by their government telling them they don't need it. And that's why they're sick. And that's why they're dying. So I can't tell you which country has the best because I don't know. And I don't have opinions about things that I don't know. I do know how to fix it, though. Again, it all comes down to the phrase, power to the people. Power to the people. Stand by. Take that power away from the big corporations and give it to the people. After all, it's their health care. There's all kinds of shady deals being cut right now between what are called third-party administrators like Cigna, United Healthcare, Blue Cross, and the plans that they administer. They administer plans for employers. They're called ERISA plans. And these ERISA plans are governed by federal laws. But basically every employer that's large enough can have a health plan, and they can't manage it themselves. Usually they have to hire a company like Cigna and the United Blue Cross to manage the plan and the benefits. So they are writing contracts now. These contracts were never written this way in the past, but the third-party administrators, say Cigna, is actually getting bonuses now if they're able to save the corporation money on payments to insurance benefits for their employees. In other words, if the company puts aside $1 million for medical care and Cigna is able to deny enough treatments for the employees over the year to where they don't spend $1 million, they spend $900,000, then Cigna gets like 50% of that $100,000 that they saved for the corporation. Well, basically, they're incentivized to deny people's medical care financially, and that's not right. I've talked to our attorney about it. In my opinion, this is literally an issue that should be taken up by a group of lawyers who understand ERISA law, and they should literally sue the hell out of the insurance companies for violating ERISA law. ERISA law does not allow for a third-party administrator to benefit from denying care to patients. They're supposed to be on a fixed payment that's independent of denial of care. But they're totally incentivized and biased to deny doctor-ordered treatments and tests because they're going to get a bigger bonus at the end of the year by saving money. There's a name for this, and I forgot the name for this language in the agreement. But 20 years ago, this didn't exist. The third-party administrators didn't get bonuses based on denying care. Now they get bonuses by denying care. They've written these into their contracts with the employers. This is not the employer's idea. This is Cigna's idea, Blue Cross's idea, United Healthcare's idea. It's just another scheme for them to become even richer at the expense of the public's health and well-being. And that disgusts me. I don't mind if they do it, but they need to tell people about it. They need to tell all the employees, by the way, if we deny enough treatments that your doctor wants you to get, we get a big fat bonus for the money that would have been used to pay for your medical care. Be honest with people. Let them know what you're doing. I'd like to see that fly. There will be people with pitchforks showing up at work, you know, looking for Frankenstein. Why are you asking? Yeah, we've got about 3 minutes left. Huh?
Who's hungry?
Right, I'm hungry. What time is it anyway? 11:25. Yeah, this is our hardest case for sure for the day.
Can you go and make sure the crew now for clean the room? Stand by.
Yeah, let's get everything ready. Just about done. Let me see here. Yeah, see those fibers right there? That means we're at the end of the disc. So I just got 2 minutes left. How much propofol do you need?
I'm good.
You're good?
No, I'm driving for the next phase.
Oh, okay.
No, I have enough for it. Finish this.
So,
It's just his head stretching once again.
oh, okay. Yeah, we're almost done. I just need to get this little piece out and we should be good to go. Any more questions? So for those of you watching this surgery, you're watching Deuk laser disc repair. 3 levels, 3 discs, L3, 4, L4, 5, L5, S1. We're all herniated on the right side, pinching the nerves, going down the leg. This patient had back and leg symptoms. I believe that they're going to be completely gone now. I believe his back pain will be gone when he wakes up, and I believe his leg symptoms will be completely gone from the surgery. I feel really good about the surgery. We got everything done that we wanted to, and we were able to get all the discs treated, even L5S1, which is the hardest to get to. And I think that this patient's going to do really well, as long as he doesn't re-injure his back. I know him. He's a workaholic. He loves to work. He's a very hard worker, like most everybody I know and meet. And he's going to want to get back to work doing stuff soon. But I know his mom as well, and she's real tough. I think she was an Olympic swimmer. And she's going to make sure he behaves. Right? Yeah. And if I fix his back, just so you know, Scott, if your back pain's gone and I fix your back, there's something I want from you. I want you to help fix Arias's Go-Kart so it doesn't slide all over the damn track next time. Because that's so annoying, going all the way to Miami and losing because your Go-Kart isn't set up properly. It's kind of a beginner thing. Arias beat the number 2 in the world this weekend. He came from England to Miami to race, and Arias beat him on Saturday. Beat the smack out of him, actually. Arias came from 44th at the end of the grid and drove right past him. Actually finished 2 positions ahead of him. Taylor Barnard just finished number 2 in the world in seniors in where were they? Norway? Finland, I think. Finland was where the world championships were. We didn't make it this year. We just didn't have the funding. Didn't have the the engine. What is that stuff going by? You see that? Do you see that, Luis? There's like a little bit of dark stuff going by. Huh? Yeah. Yep. So the world champion in go-karting is a guy named Lorenzo Travassanuto. He's Italian. And Arias beat him last year in Miami, soundly. And Arias beat number 2 in the world this year because Travassanuto won a second year in a row. So Travassanuto wasn't in Miami this weekend, though, to race. He stayed over in Europe. But number 2 in the world, Barnard, was there, and Arias beat him on Saturday. Unfortunately, we didn't have the go-kart to beat him on Sunday because it was sliding everywhere, but hopefully that'll be fixed for the next round. Arias will be racing in February. I think it's 7th, 8th, and 9th that weekend at SCUSA, Superkarts USA. All right, we're pretty much done. You can see that the annular tear has been debrided completely. I'm just going to zap this stuff right here. This is the last of the herniation that we shoved in from the outside of the disc. And we're pretty much done. 30 seconds. Oh yeah, that's true. I just thought of something. We were in the same tent as the number 2 in the world, Barnard, this weekend, and I just realized his team never came over and helped us with our go-kart. And I understand why, because we beat him on Saturday so badly. They didn't want Arias to beat him again on Sunday, so they actually probably gave us misinformation about the setup so that we were sliding through the final. Interesting. Just goes to show you it's a dog-eat-dog world, even in racing, especially in racing, right? But I'm not doing dog-eat-dog stuff. I'm trying to teach the world about spine surgery, even surgeons out there that want to learn. So, just a very different attitude. All right, we're all done. Standby laser. Let's see. You can see the nerve root right up there. Okay, and looking good. Let me zap this little nugget right here. Just underneath. I want to make sure it's not compressing the root in any way. Yeah. It's not, which is good. Just to be safe though, I don't want to leave anything there. I like it. Very happy with that. Stand by. So, I know my son could be a neurosurgeon if he wanted to be. And part of him I know wants to be. But he has an opportunity to be, I believe, a world champion in Formula One. I've seen it since he was 1 year old. So we want to give him that opportunity. But I would be happy either way. Okie dokie, so let's show our audience the incision. We're all done. Let's get the gurney ready. Let's get the floor out of here. Come on, start moving. Don't stand around. We're going to need to get this patient on the gurney to recover him. So I'm just putting a little bit of pressure medial to the incision. I don't want the muscles oozing any blood. Hey, you're all done. Everything went well. His elbows are good. Can you see the incision here, Sean?
Yes, we can.
All right, so compare this endoscopic surgery incision versus the incision we would have had to make, which is basically this entire area. And then look, he's going to be out of here in an hour. He's going to do fantastic. And he didn't get screws and rods. He didn't get open surgery. So it's a remarkable thing that he doesn't have to have such a major surgery to get better. Hopefully we can interview him. You'll see just what I mean by how tall he is. Thank you. All right, I'm going to head over to the conference room. If you have questions, folks, type them up, and I'll answer them for you. This is the time to do that. Also, Deuk Spine Institute has a new app called the Deuk Spine Institute app. It's free. It's available on Android and iOS platforms, so go ahead and download it. It's got lots of good information, places to go, interesting facts, testimonials. You can also arrange for a free video conference to meet me face to face and have me diagnose your problem and tell you what needs to be done. All right, we'll be over there shortly. Oh, one more thing. We have a spine surgery support group. It's free. You don't have to pay to get in. And you go to Facebook and apply for spine surgery support group membership, and we'll let you in. You can ask questions on there, and hopefully we can help you out.
All right, thank you for joining us for the post-op Q&A. We have Dr. Deuk in the room. One of our viewers is asking, do you often see discograms coincide with the results of an MRI or an X-ray in regards to pain correlating with the size of a herniation?
Great question. Hi, Dr. Deuk here. So the question from one of our viewers was, does the discogram results typically correlate with the MRI findings of large versus small herniations? The answer is 100% no. They almost never correlate. As a matter of fact, that's part of the reason why at least a quarter of the patients come to me is because they have an MRI that shows a small herniation or a small disc bulge at one of the levels, and they go and see all these doctors for care to get cured, get rid of their back pain, but the doctors say, hey, you've got nothing wrong with your spine. There's nothing wrong. Your MRI looks good. There's nothing wrong with your MRI. It's fine. But the reality is that they have an annular tear with a disc herniation, and that is the source of their back pain. And the other doctors don't give credence to that because they're used to the ideology or dogma that size matters, and that if you have a small herniation it won't hurt you, and if you have a big herniation it will. And the reason why they've been fooled into believing that is because they believe from their training, from misinformation, fake news from their teachers at the university where they learn. They've been taught that it's the squashing of the root, the compression in other words, that determines the symptoms. But in reality, that's only true for 10% of patients with herniated disc. Only 10% of patients with herniated disc have symptoms from compression of the nerve root. The other 90% that have radicular symptoms or nerve root symptoms from the herniation, it comes from inflammation of the nerve root by the herniation, and that has nothing to do with the size of the herniation. It has everything to do with whether that the nucleus pulposus is wedged in between the annular fibers and whether or not the annulus has successfully walled off the nucleus pulposus to stop the inflammation. So in most cases, obviously, people with back pain and leg symptoms from a herniated disc, they have not successfully walled off the herniation with scar tissue, and they're still getting inflammation. So that's why they're there, seeking treatment from a doctor. So 90% of patients that have horrible back pain from a herniated disc or horrible leg symptoms from a herniated disc, it has to do with a small disc herniation, which we call a disc bulge, a bulging disc. All right, and it's completely fixable with surgery, with the Deuk laser disc repair surgery. It could also be fixed with a fusion if it's done properly, but most surgeons don't do the fusion properly, so they don't get rid of the pain. So the key is you have to go to the right place with the right surgeon to get the right procedure done. That was our only question. Thanks for being such a great audience. As always, it's a pleasure. For those of you not used to hearing a doctor speak the truth about things, well, this is what it sounds like. And if I offend people, I'm sorry, but it's too bad. I'm paying for the show. You're getting it for free. So you can enjoy it and learn from it and accept the truth for what it is, or you can just go somewhere else and continue to be lied to and keep believing in your fantasy world. But the reality is that medicine is suffering badly, and it's not just spine care, it's all areas of medicine, and it's all due to one thing: greed by the insurance industry, where they're not paying for things to be done anymore. Nursing homes have gone down the toilet. Nobody wants to be in a nursing home anymore because the quality of care is so bad. Well, why is that? The reason is simple. The payments to the nursing home have deteriorated. Medicare has cut them and cut them and cut them over and over and over again. And it's gotten harder and harder to get paid. So the revenue to the nursing homes has gone down over the last 30 years because the insurance companies like Cigna and United Healthcare, and most notably Blue Cross Blue Shield, they are managing Medicare now, and they've been managing it now for, I don't know exactly when they started, but I would love to hear from our audience if somebody knows when the MACs, MACS, Medicare Administrating Companies, which are basically Blue Cross Blue Shield, Cigna, United Healthcare, and Aetna, and Humana, they basically carved up the United States and said to Medicare, we're going to take control of, paying for these people's Medicare beneficiaries' care, and we're going to be able to deny what we want to deny, and we're going to get paid for denials. That's essentially the deal they cut with the government. They are being paid to deny payments for Medicare services. And by saving the government money, they get a percentage of every dollar they save the government. I believe that percentage is around 30% if you add everything up. So they're basically making 30 cents on every dollar they save Medicare, which means nursing homes are getting underpaid, hospitals are getting underpaid, doctors are getting underpaid, therapists are getting underpaid, chiropractors are getting underpaid, pharmaceutical companies are actually getting underpaid. I never thought I'd be defending them. I used to hate them because they charge too much money. But the truth is that everybody's suffering. The entire healthcare system is suffering because of the greed of the insurance company. So America, wake up, get off your ass, and go do something about it. And that something is you have to elect state politicians and federal politicians that are willing to pass laws that take away the insurance company's ability to deny medical care to patients. That should never be their ability. Insurance companies should never be able to say no to a doctor-ordered treatment. Now, could you create a panel? If you don't believe the doctor's right and the doctor's wrong, create a panel. Create a panel, but don't let it be controlled by the insurance industry. Let it be controlled by people who actually care about other people. And if you do that, the panel will make the right decision. So take away the laws that let the insurance companies deny payments to providers, including hospitals, doctors, therapists, etc., nursing homes, MRI centers. Take those laws away. Fix them, because they've been changed underneath your nose, behind your back. Those lawmakers have been lobbied by the insurance companies, and they've slowly, quietly, like a cancer, changed the laws in your state and the federal government to take control of healthcare. But the most important power they have, I don't know what you want to call it, in every movie that has evil, there is always a power, okay? And that power, for example, in the most important movie ever made is Star Wars, and The Empire Strikes Back, and The Return of the Jedi, the original Star Wars series. That power that was created by evil to be used for evil purposes was the Death Star. And for those of you who know what the Death Star is, it was created by the evil empire, and it was used against innocent people, to destroy planets and kill people. And the Death Star for the insurance companies is the ability, the laws that let them deny care by calling it experimental or not medically necessary. They have created the Death Star. They've created the laws by using politicians, tricking politicians to pass the law, write the law, and pass it. And now those laws that allow the health insurance companies to deny care are the Death Star. And they're using it basically to destroy medicine, because everything they destroy means more money in their pocket. Their premiums keep coming in every year, per covered life, so the money coming in is going up, 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 and the money they're paying out due to the Death Star is going down, down, down. So what happens when your revenue goes up but your costs go down? You make more profit. That's pure and simple. It's greed. So I'm making you all aware the Death Star exists. It's destroying all your lives. It's up to you to go take it down. Okay? Bye.